Okay, we left off the last video on the intro of posterior cerebral artery, and the pattern with which we are going is that we discuss what does the artery supplies and what does that certain part of the brain functions or manifests as in the body. So revising a neuroanatomy a little, occipital lobe majorly takes up all the visual signals. Through the optic nerve, which you see, what you observe, what you interpret, what you're reading and writing, the interpretation. When you look at an object and you go like, yeah, I am looking at a light. All that observation, interpretation, all those tiny things that are controlling your visual memory, your visual interpretation of the objects, your vision is the occipital lobe. Other than that, this posterior cerebral artery, the good thing with this is this does not only supplies the cerebral cortex, it also supplies the portion. We have an idea that between two cerebral cortices we have the corpus callosum, and under the corpus callosum we have tiny certain structures which have different functions throughout the body part. We have thalamus, we have hypothalamus, we have different memory centers within the brain. So posterior cerebral artery not only supplies the cerebral cortex but also supplies those internal regions. So if you look at the book, the NPT and its table, it is divided into two centers, the middle area and the peripheral area. The peripheral area majorly covers up the lobe, and the middle area majorly covers up the thalamus, the hypothalamus, and the areas this artery is supplying. So now you got the idea that what is the major function of this posterior cerebral artery. Now if this artery gets damaged, gets blocked, the blood supply couldn't go to the occipital lobe, how would that manifest in a patient who presented to you with stroke? The first thing that comes up to mind is the optic vision. All the optical things, all the visual things you have in mind will be gone. The patient won't be able to observe what is in front of him or her. For example, if visually there's visual interpretation, I'll also present it in. I'm explaining to you guys first in layman term, and then we will go through the terms that are, for example, agnosia, prosopagnosia, that are explained in the medical terms. First thing is, if half of because mostly we see that stroke presents itself as the unilateral side, not the both sides, right? The unilateral side, the optic nerve, if you revise neuroanatomy a little, we have the left side and we have the right side. There are two branches of the optic nerve. First, that supplies the left side of the ipsilateral eye and the left side of the contralateral eye. This is the classic nerve that supplies both sides half-half. Like if we are looking left side of this portion, left side of this eye, both of these are supplied by the optic nerve of my left side. The right side of this eye and the right side of this eye, ipsilateral and the contralateral, both are supplied by the right optic nerve. So if one of the areas is damaged, the patient won't go blind, but the patient will go into a condition that they will only be able to observe through the right side. They will be able to see the right side vision, but they won't be able to interpret or see the left side vision. This condition in medical term is called as homonymous hemianopsia. Homonymous hemianopsia. Anopsia you're not able to see properly, and hemi half center. First term we've covered. There a little bit of difficult terms to remember because you most of the time mix them up. So please pay attention to the words and find the keywords that can help you remember that what was it for. So anopsia you are not able to see completely, and hemi half the center. We covered the first term. Right now in the occipital lobe, I'm explaining to you guys the table, the peripheral symptoms that the patients present with the PCA syndrome. Next is agnosia. When I explain to you guys homonymous hemianopsia, it's not like the patient won't present with blindness. It might occur if both of the occipital, the infarct or the hemorrhage was huge and covered both the occipital lobes, the patient will present with blindness 100%. But most of the time it doesn't occur. The hemorrhage mostly occurs in one side, not the both sides. So if both sides, it's blindness. If one side, it's homonymous hemianopsia. Then in the occipital lobe, you have two terms, agnosia and prosopagnosia. And dyslexia, that's the most classic term. Everyone knows about it. You have seen that movie, Chap. In agnosia and prosopagnosia, you have an object in front of you, a marker. Or for example, when someone says the word apple, you hear it, and then you form a visual image into your brain, a red colored apple, right? The person won't be able to interpret the things or the words you say in a visual image. That is called agnosia. The prosopagnosia, it's kind of similar, but in prosopagnosia, the person won't be able to remember the familiar things or objects or faces. For example, they saw a marker 2 days ago, and then when they see that thing again, they'll go like, yeah, I have seen this, but I don't know what that is. The connection of the visual cortex with the Broca's area, with the thinking process is lost. So the patient's interpretation is lost. They are not able to interpret this as a marker. But if they can interpret, but they don't remember the familiar things, they don't remember who you were that they met 2 days ago, and they don't remember, oh, I've seen you somewhere, but I don't know who you were. Remembering, or the familiar faces they have seen before, that's called prosopagnosia. Dyslexia is a condition in which you interpret or imagine things in your own brain, but you see the words dancing and everything, that's a whole different imaginary world, but it's not real. Okay. Other than occipital lobe, we've covered the peripheral symptoms, right? I just explained to you guys that in the brain there is a peripheral center. If you look into this version, that this is the cross section of the brain. You have the corpus callosum, the thalamus, the hypothalamus, then the cerebellum, and then the whole of the brainstem. So in this area, the peripheral the areas are covered, but the middle areas are not. So in the middle, thalamus, half of the thalamus is supplied by the posterior cerebral artery. So if the posterior cerebral artery is not supplying the thalamus, this is the only type of stroke syndrome in which the patient will present with pain. If your thalamus is infarcted or your thalamus is not working properly or damaged, your patient will interpret pain. So that's the classic sign in PCA, you can interpret pain due to stroke. All the others, we already know that in the brain there are no nociceptors, right? But in this case, if the thalamus is damaged, the patient will present with the pain called as post-thalamus or post-stroke the thalamus pain. Okay, we have covered this. Other than that, it also supplies the inferior anterior supplies. There's a temporal lobe here somewhere, right here. So the inferior portion of the temporal lobe are also supplied by the posterior cerebral artery, and in there we have a small center that covers up stores up our memory. So in this posterior cerebral artery syndrome, you will come up with the memory deficit as well. And all of these symptoms that I've told you guys, post-thalamic pain, memory deficit, present due to PCA syndrome in the middle portion. Next is Weber syndrome, classic. If the patient presents with Weber syndrome, and Weber syndrome you have already read and crammed it back in second year in neuroanatomy. Weber syndrome is the third nerve palsy, the oculomotor nerve, that also controls your visual centers, and other than that, the contralateral hemiplegia. You combine these both terms, and it is combined because in medical terms, why do they combine two different diseases, two different manifestations in a patient, combine them together? Because most of the times those two manifestations present together in a patient. So Weber syndrome mostly presents in PCA, third nerve palsy, and contralateral hemiplegia. We have covered the PCA. That's it. The most important thing you need to remember is homonymous hemianopsy and how does the occipital lobe presents itself, the damage of occipital lobe presents itself in PCA syndrome in stroke patients. Now, these were the three diseases that I already covered, the ACA, the MC, and the PCA. And to be honest, if you want to pass your exams, these are the three you need to remember, and the other two you don't have to go through those large pages and large tables and cover them up. No. You just have to get a little bit of an idea what stroke is, what vertebral artery syndrome is. So we'll just touch these topics, but as an undergrad student, you don't have to remember or cram it at all. Leave those books, leave those pages. Now, in lacunar stroke, the word actually presents, in lacunar stroke, you know that in your brainstem, the outside is the gray matter and the inside is the white matter. In contrast to the spinal cord has white matter outside and the gray matter inside. But the brain, the past three syndromes that we have discovered are of the gray matter mostly, and the white matter, there are parts of it. But the lacunar stroke presents mostly in the infarcts of the white matter. The small arteries, your brain is not a hollow structure. The cortices are not hollow. We have imagine this is the cortex, right? And we have a motor homunculus going through here. We have the motor homunculus going through the borders. But what is inside? It's a white matter. And there are small arteries supplying that white matter. So lacunar stroke will present if those small arteries rupture due to hypertension, due to certain aneurysm, due to certain diseases. Most of the time it's not ischemia, it's hemorrhage in the lacunar strokes. Small artery supplies, and wherever, it's not like we will have to remember all those small tiny arteries. There will be like millions of arteries within the brain. So all you need to remember is the lacunar stroke. Wherever the artery bursts or ruptures, the patient will present with those kind of symptoms. It can be internal capsule, it can be the basal ganglia, it can be when the patient presents with the diseases, the manifestation of basal ganglia and all the other tiny structures with that artery supplying to that structure, right? So that's it. You don't have to remember anything about lacunar stroke other than that the small arteries are ruptured. Okay, the fifth and the final syndrome that we have in stroke is vertebrobasilar artery. And vertebrobasilar artery in itself, if you start to study that, you'll have to conceptualize vertebrobasilar artery for 3 weeks at least, because vertebrobasilar artery supplies all of your brainstem, all of your cerebellum. The only thing you have to remember here is brainstem is a complex structure. You have medulla, you have pons, you have midbrain, you have cerebellum, and the 12 cranial nerves pass from there. So if the artery is damaged, the vertebrobasilar artery, it will also damage those cranial nerves. So the patient will present with all of the cranial nerve deficit. You check your cranial nerves. For example, if you look at the hypoglossal nerve, the glossopharyngeal nerve, the vagus nerve, all of those will manifest in a different kind of pattern, and suddenly only one nerve is damaged. We know that from pons, 5th to 12 arteries, 5th cranial nerve 5 to cranial nerve 12 pass from underneath the pons area, the pons border, right? So the vertebrobasilar artery supplies the brainstem. The only thing you need to remember that can be asked in Viva questions is locked-in syndrome, and it's that I just discussed with you guys, that if the anterior pons area, for example, if this is pons and 5 nerves, cranial nerve 5 to 12, 5, 6, 7, 8, 9, 10, 11, 12. If these nerves are passing from here, their routes are from the pons. If this area is damaged, all those nerves will manifest itself, and that disease is called as the locked-in syndrome. If the ventral pons is damaged, that's it. You don't have to remember anything other than this. Okay, next is complications of stroke. Now regarding, can you see till the end? Yes, you guys can. Okay. Now the complications of stroke, you already discussed every little detail in these syndromes. Now think in your brain that we had a patient with stroke, and all the medical facilities were given to them to save the patient. But now the patient is alive, but the patient is presenting with paralysis, and they did not get any physiotherapy treatment, any rehabilitation. So those sparsity symptoms that we discussed, that the patient has homonymous hemianopsia, and before in the AC and the MCA, the patient has lower leg paralysis, the patient has the upper limb paralysis, and nothing's been done to fix that. So all these conditions will insidiously deteriorate into the worst conditions, right? So these are those worsening of those symptoms that we already discussed. It's called as a complication of stroke. It's pretty easy. You have to conceptualize, not cram it, okay? Speech and language. Where did we read the speech and language thing? The person won't be able to speak and everything. MCA. We learned about the fluent aphasia. We learned about non-fluent aphasia. We learned about global aphasia. All those symptoms, remember those symptoms in your brain regarding the ACA syndrome, the MCA syndrome, etc., and take it long term, that the patient has those conditions for 6 years, for 7 years. It is called as complications. If you look into your book, it's not like you have to read and write every page. Like, look at this. Disorders of speech and language, dysphagia. The only thing you need to remember here is the cognitive dysfunction, because we didn't discuss any cognitive dysfunction thing. And these two are the new ones. Other than that, everything is what we have already understood and conceptualized. In cognitive dysfunction, actually, even we also discussed the cognitive dysfunction here. Memory deficit. So if the memory deficit centers, the temporal lobes are already damaged, and there's no all those areas cannot be fixed. So the memory deficit goes on for a long period of time, for 6 years, for 7 years, God forbid for 10 years. So the memory deficit is not just the patient won't be able to remember what happened. They won't be able to store the memory that's been going on, the things or events that are going on in their life. They won't be able to remember it, because those centers cannot interpret or store the memory. And then other than that, there's a word called as confabulation in cognitive dysfunction. it is that if the person, it is actually a psychological kind of thing, that the person does not remember a certain part of their life, for example 10 years ago or 11 years ago, and they make up a story by themselves that yeah, I studied there and I got married, when in actual life they didn't get married in that certain part of the era or time. So they make up stories to cover up their time lapse that they don't even remember. That's called confabulation. Attention span, the basic attention span of a normal human being is 20 minutes or 30 minutes or 40 minutes, depends on the person, it's variable. But in these people, the cognitive dysfunction with stroke, they won't be able to pay attention for a very long period of time. And other than that, emotional dysfunction. Sympathy, empathy, it's now you empathize with the person, you sympathize with the person, but the patients who present with stroke, they are not able to feel any emotions, they are not able to sympathize or empathize with the patients, and that condition is called as apathy. Delirium. Delirium is that the person goes into that cycle where they're thinking that they're making up stories or imagining things, and it can go into a very worsening condition that the person might start to feel. For example, there's a word called nightmares, right? If they go up in a very huge pattern and they are imagining things when they're awake, fully awakened, that's called as delirium. The pseudo-bulbar effect. This is a broader term that covers up all the emotional dysfunctioning or the emotional dysfunction that the patient presents with. Pseudo-bulbar effect, the PBA, it also goes a long way in psychology and in neurophysiotherapy, that the patient won't be able to emotionally regulate themselves. That's part of pseudo-bulbar effect. The depression and euphoria. Depression, all of the happy moments or the memories where the patient is enthusiastic to do or motivated to do the thing, depression. And in the exact contrast of that, euphoria, when the person is in the highest state of happiness. So sometimes you meet a patient with stroke, they're the happiest. The next moment they're in depression. The next moment they cannot feel anything. So that's emotional dysfunction. Bowel and bladder dysfunction. We have these two are the ones that not commonly present in stroke, but in 10, can you see the last two? Is it bowel and bladder dysfunction and cardiovascular changes or DVT? These are not very important for stroke patients. It's actually not a consequence of stroke, but it's for example, if the patient has a cardiovascular disease and they present with MI, and because of MI, the person got stroke. But if the actual problem is not cured up, the person can reappear with those symptoms. That is, the person can get MI again. So also it comes up in the complications one way or the other. And we have the bowel and bladder dysfunction. That's actually a huge manifestation of traumatic spinal cord injury. But in 10% of the patients in the acute stroke, for example, for the first 72 hours, the patient won't be able to control their bowel and bladder. They're in complete flaccidity, and that's how they present. The last part, I don't know if you can see this, is DVT, deep venous thrombosis. This is a pure consequence or complication of stroke, and it is not in one way or the other. It is not connected to any part of the brain that could not supply or that got infarcted. No. Any person who stays in bed for a very long period of time, for example, if maybe they might be paralyzed, they might have surgery and they do not have the will to move, the veins won't be able to supply the blood back to the heart, and stagnant blood, you need to know that when the blood is stagnant, all the clotting factors compile together, clump together, and form this thrombus that can lead to huge infarcts within whole body. So that is a pure complication of sedentary lifestyle, not waking up from bed, not moving from bed. It's kind of a manifestation of all those diseases in which the person is not able to move from the bed. It can be MI, it can be all of the diseases, right? Okay. We have covered up all of those syndromes we had in stroke chapter. Now we're going to go to the examination. And other than that, I need to tell you guys that all the for example, we had complications, we have the medical diagnosis of stroke. You don't have to cram each and every topic. You don't have to read all of the books. Just go through the titles of the paragraphs, and if you think that they are worth reading, go read them. Do not cram them. It's not worth it, and you have to remember everything in this book. Only 4 to 5, if you want to get distinction, like in actual med school, you can remember up to 7 the titles of the certain. For example, in complication, you just have to remember the 5 to 7 the titles, and then you can write if the concept is clear about those titles. Okay. The next thing is diagnosis of stroke. This is you're going to cover this pretty much in medicine. That's not part of NPT at all. So the only thing you need to remember is for diagnosis of stroke. For example, imagine a patient coming up to you. For example, in Gray's Anatomy, there's a scenario the patient presents, and you have to go through the medical diagnosis and then treat them. Create a picture, create an episode that you have a stroke patient, and how does the medical diagnosis go for that certain patient. If the person presents with stroke, you know that the body, half side of the body is flaccid, the person's attention span is lost, and there's a history that yes, the person might have hypertension, the person has uncontrolled hypertension, or the person got into RTA, the road traffic accident. The first and foremost thing you need to get that patient done is CT scan and MRI. Between two, there's a fight that CT scan is the first line imaging that you have to get done for stroke, but in CT there's the thing that it also majorly covers up the ischemia. You get the CT done if the person has ischemia that come up, but in MRI the hemorrhage is best seen in MRIs. In the MRI interpretation, if you read the radiology in fourth year as well, you can coincide side by side that when you get the MRI done, the whole of the area is black. The brain in the MRI is shown black, but the infarct or the blood leakage is shown white. So that's in MRI. And ultrasound, not many people explain this, that if you have small artery bursts that coincide with the lacunar strokes, a small artery burst can only be interpreted on ultrasound. And that's it, we have covered this as well. Now, highest yield topic of stroke. It comes up so many times in exam, and the drawback, the flaw of this book that I've called one is they didn't explain that there are two names for this examination: the stages of motor recovery. Yeah. Now the next topic story, right? In this, the two things that you have to remember is in examination, this portion. And this is pretty much something that every person should have in mind without cramming, that how do you want to present, how do you want to examine a patient, what is your purpose of examination. The first and foremost purpose of examination is you want to diagnose properly, and if you got the diagnosis, you have to tell the patient if you can treat the patient. In physiotherapy, you have to be very, very logical and honest with your patient's attendance, that can we fix this stroke, can we fix the pathology that the person is going in with. Okay, and the next thing, yes, plan of care, and if you can treat the patient properly up till you can never get the patient of stroke up to the 100% level of the pre-stroke presentation. If the person was standing or walking, or he was an athlete who got into stroke, you cannot get the patient back to the tracks or the fields they were in. So we have covered this. Now covering up with examination. In examination, you only have to I'd say cram these two topics. Can you see up till the pusher syndrome from them? Okay. 3 stars for the SCQ question, and a huge star for concept, because when the person presents with stroke and as a physiotherapy major, you have to interpret that what is the stage the person is going on in, and if you're treating the patient, you have to examine the person month after month or week after week to see if the patient's motor recovery is happening or not. So in examination, you have to remember that there are stages of motor learning, you do anything or not. For example, if the person has frozen shoulder, you already have this concept that after 2.5 years, the frozen shoulder is self-limiting. It treats itself. So same happens with stroke, and if the stroke was not that huge that the patient dies, if the patient survives, there are stages of motor learning. We're only talking about the stages of motor learning right now. And how does it present in exams? It's called as it actually occurred in my exam called as the Brunnstorm stages of motor learning. The only thing we remember is stages of motor learning. You don't remember that word or focus on that word Brunnstorm. There are so many stages or strategies of motor learning in neurophysiotherapy that it doesn't click to mind that which one of the stages of motor learning you have to write in that exam. So it's Brunnstorm's stages of motor learning. For future reference for your exams, high yield topic, 3 stars. Starting with stage 1. Now imagine a guy who presented with ACA stroke. We can take up, this is a scenario, I'm going to explain to you guys this through a scenario, and that it's really hard to grasp. ACA stroke. Initially, the patient presented with stroke, and within 72 hours, the patient's body will manifest the motor system. They won't be able to do anything. Flaccidity, huge. Like you cannot see that part of the body. For example, if the left side of the body is in paralysis, there won't be a single muscle that is spastic, or a single muscle that a person can control. It feels like that part of the body is dead. For 72 hours or more than that, in the acute stage, in the initial stages, stage 1 is the complete paralysis, complete flaccidity. The person cannot even move one part of the muscle, the finger, or anything. Okay? That's stage 1. In stage 2, now the person's that certain part of the body, the left side, is not flaccid anymore. After the stage 1, it manifests into stage 2 by spasticity. I really hope that you guys remember the difference between flaccidity. Flaccidity is your body is limp. It's like it's dead. You can move the person. Move, for example, if I the spasticity is all. It's all concept, and I really hope you have the concept of spasticity and flaccidity. Synergy patterns. This is a huge term, and everyone in Viva asked about the synergy patterns. The body was limp. Now in stage 2, the body the muscles start to tighten up, and if you're someone doing exercise, doing clinicals, you'll see that the patient who presents with stroke for a month, their body is so stiff, the muscles are so stiff that you cannot move their limb to the even to extension or flexion. They cannot interpret it. They cannot explain because it's involuntary. They cannot do it. They're not doing it on purpose. So, synergy patterns start to appear. From flaccidity, you moved on to spasticity. First is 3 arrows. You cannot even move a muscle. In the second section, synergies is, for example, this guy after 72 hours. Now you have the patient wanted to. The voluntary control came back, but only up to 20%. I'll explain it in the percentage form. The person wants to move a finger, or the person wants to flex their arm. But if they want to move just one segment, if one joint, there will be a pattern in which the 3 or 4 movements combined together, and that's involuntary. For example, I'm a stroke patient, ACS or MCA stroke. I have upper limb paralysis, and I wanted to move a limb. And if I try to move a limb, the other hands try to move together, and this is a synergy pattern. They just wanted to move an elbow and went to do the elbow flexion, but the shoulder abduction, the shoulder flexion, the wrist flexion, the fingers flexion occurred with it in an involuntary motion. That is the easiest definition that I can give to you guys about synergy. Synergy is the uncontrolled movement that you did not want in your body alongside the movement that you did to your body. Get it? So I'll teach this stage of motor learning alongside these images. If you can see these images, they're really good. Okay, we're talking about this. In stage 2, the synergy patterns start to appear. It's not like you can do all the way. It's like the person wanted to move, but they went like this. It's the initial stages. The synergy patterns also presented in like 50%. But if you go to the third stage, now the voluntary control, in the second stage, the person wanted to move, but the synergy pattern occurred with that, but up to 50%. It's not that all the synergy patterns went all the way up. In the third stage, the person can, the voluntary control, they're regaining the voluntary control as well. They're regaining their voluntary control as well. But the spasticity is increasing side by side, and that's one of the saddest things you can hear today about this stage 3. They want to now, in the initial stage, remember the stage 1, the patient wanted to move but they couldn't. Right now they have control over, in stage 3, they have control over all 5 of their fingers. They can control their fingers, but it's so spastic, so stiff. It feels like someone is holding their fingers from outside, and they cannot move their fingers, but they want to. And they have control. They can do it, but the muscles do not allow it. That's stage 3. In stage 4, Now it's like the bar, the happy bar is going up and the worsening bar is going down. The voluntary control, they're gaining more and more voluntary control, and the spasticity is decreasing. So in stage 1, all the way down. In stage 2, spasticity and the synergy pattern started going up. In stage 3, the spasticity got all the way up, but the voluntary control also got up. In stage 4, your voluntary control, the patient started gaining more and more voluntary control. In stage 3, hands and then elbow and then shoulder as well. So the voluntary control is going up and the spasticity is going down. But this alongside that, there's a third bar of synergy patterns. And synergy patterns we will discuss in detail how does those manifest after we discuss this, because side by side it's very confusing. So in stage 4, voluntary control goes all the way up. Now you can control your arm, you can control your shoulder, you can control your neck movements, but the muscles that were extremely stiff are now going down. Now they are moving. The person, you observe that yesterday the person wasn't able to move their head side by side, but today they can move their head all the way. They're trying their best and they can move their head all the way. The spasticity is going down. In stage 5, they're learning new movements. They're remembering the past movements. That is stage 5, and in this, mostly the spasticity is gone completely. But in stage 5, the thing is that there are new movements, but the coordination is lost. They want to pick up and drink a glass of water, and you need enough coordination to do that. They can pick up a glass, but they cannot bring it up to their mouth to drink the water. The coordination is lost, and most of the times, if the patient is the motor learning pattern is improving in them, they'll stop here. Most 90% of the cases, they cannot go up to the life that they had without stroke. They cannot. The coordination, the movement is restored with coordination. Because these two are very confusing. The person got new movements, the person does not have any synergy pattern exactly like us. But the coordination is lost. That's the key point in these two stages of motor learning. Now we're coming up to the second high yield topic of stroke, that is synergies. We got an idea in a very, very simple and layman term that I wanted to move a finger, but when I tried, voluntarily I just tried to move a finger. But alongside that, all the other muscles in the body limb crumbled up and formed a certain kind of position. This is a synergy pattern. And there are 4 kinds of synergy patterns that presents in stroke: 2 of upper limb, 2 of lower limb. Flexion synergy pattern and extension synergy pattern in upper limb, and flexion and extension synergy pattern in lower limb. In upper limb, flexion synergy is that the person wanted to flex their wrist, but alongside that, the shoulder will flex, the shoulder will abduct. I'll explain to you guys like this. The shoulder will flex, the shoulder will abduct, your elbow will flex, supinate, and your wrist will flex and your hand will flex. I just want, as a stroke, if I'm the stroke person and I want to move my limb, and they will present like this. This is the first presentation of flexor synergy. The second one is extension synergy, and in extension synergy what occurs is the person wanting to extend or flex their fingers or do any kind of movements they want to do, extension, flexion, whatever, when that certain limb. The person's shoulder will abduct, and this movement is very rapid and fast. It's not like the movement got done very slow and insidiously. No. Want to move a finger, alongside that they'll do this. That's it. Okay. The shoulder adduction, the elbow extension, elbow supination, and then wrist flexion, and the wrist flexion, the fingers flexion as well. The flexion pattern is same in both of the cases. So in extension synergy, if they wanted to flex their fingers, what happened is all of their hand will go like this, and this is the extension synergy of the upper limb. I won't be able to demonstrate the extension synergy because you won't be able to see up till the end. So in the flexion synergy, what happens is, in flexion synergy, in lower limb, for example, imagine the patient is lying down on a bed, right? If they wanted to even flicker their finger or even move their finger in stage 2 or any of these stages, what will happen is their hips will flex, flexion occurs, then adduction occurs. Other than that, their knees will flex, and the whole of the leg will externally rotate. And when you rotate your leg externally, your foot points outside. That's external rotation, because most of the people or students confuse external rotation with internal rotation. The external rotation is always the feet points outward. For example, if this is my lower limb, my leg, in external rotation, the feet will point outwards. In internal rotation, the feet will point inwards. Okay, so shoulder, the hip flexion and abduction, then your knee flexion, your whole hip, external rotation, your feet will dorsiflex, and that's it. This is the flexion energy. And this is a very abnormal pattern. I'll demonstrate on my arm. That's a really good idea actually. If this is my leg, this is my hips, this is my femur section, is the tibia, and this is the foot. Normally foot is in a neutral position, right? If the patient wanted to move their leg a little bit and get into a comfortable condition, what will happen is flexion, adduction, knee flexion, and your feet will point outwards and upwards in dorsiflexion. This is the flexion synergy of lower limb. Exactly like this, there is an extension synergy of this area, and in this, now all of the limb patterns will extend. The legs, this time if the patient want to move in any way, the hip will extend, the knee will extend, and the limb will move in the rotate internally. If you visualize this, internal rotation means that your feet will point inwards this time. Internal rotation, and your feet will plantar flex. So in this case, if I have an extension synergy after stroke in the lower limb, I wanted to move a limb, what will happen is my hips will extension, the knees extension, internal rotation of the feet points inward this time. Okay, and the feet will go in plantar flexion, and this is the extension synergy. Yes, that's it. In examination, you only have to remember or cram for STQ segment this portion, only these two, and all the other are just for reviewing or just remembering. Only if you remember the titles, it will be really easy for you guys to write under those titles. I'll just teach you guys from here. This is pretty much the old things. Motor segments of stages of motor learning, very, very important for SCQ. Other than that, you just have to remember the patient, you have to see the reflexes. And for reflexes, you see is you tap the patient's muscle. If it's they can present with two symptoms, hyperreflexia or hyperreflexia, that's it. This is a synergy pattern that I visually conceptualized to you guys, and you can make a diagram of for easy interpretation. Muscle strength, you already know what MMT is. How do you see that in which grade the muscle is? This is very important in a way that they can ask you in Viva questions. How do you assess postural control or gait cycle of a person? You only have to remember these names. That's it. You only have to remember the scale's name, the word balance scale, the CDSIB, the tug test, etc. That's it. For your level, that's it. There is a term called as ipsilateral pushing, and in my stand-up exam, someone asked me what is pusher syndrome, and I don't know what that was, because I actually went through these pages and I couldn't recognize this. It's actually on page number 674. You can mark this because it actually is asked in Viva, and sometimes it also came in my module SCQ. So, about pusher syndrome. The pusher syndrome is when half of your body goes into stroke. This is a normal body, right? And this is an abnormal body. When you stand up, and there's a segment in your brain that controls your center of gravity. All of this we learned in kinesiology, that we have our brains try to stabilize or balance our body on 2 feet, and the center of gravity passes right from the center. But when stroke occurs, and that certain part of the brain, that's actually the ventrolateral thalamus, I guess, remember that. You can check from the book, the page 674. Your center of gravity passes right from the center. Can you see this? Yes, you people can. It goes through right from the center, and you can stand up on 2 legs easily without falling. But if stroke occurs and half of your body is paralyzed, and that certain brain segment is also paralyzed, and you cannot interpret that you also have this segment, this side, the right side, and this is called as unilateral neglect. There's another term for that. Your brain will think that you only have 1 arm, 1 leg, half side of the body, 1 eye. The interpretation of this side of the body, the cognitive paralysis, will be gone. So if imagine your brain thinking that this side of the body does not exist, what it will do is it will try to stabilize this side, because right now I'm standing, I'm trying to, if actually you imagine a person who only has one side, and if they're standing like this, they might be able to fall towards that side they're standing on, right? So our brain tries to stabilize our falling, it thinks that I have to maintain the center of gravity. We're standing like this, our center of gravity is in the center. So to maintain the center of gravity, you have to laterally move. That's the way. That's how the center of gravity moves toward that side. So your right side, your non-stroke side, pushes your body towards the stroke side or towards the paralyzed side to maintain the center of gravity in the center. And that's just because the brain area cannot interpret that it's not just this part of the brain, this part also exists. Due to unilateral neglect, your center of gravity is actually balanced, but the brain thinks it's not balanced, it's gone towards the other side. You have to maintain, it thinks that the center of gravity should be balanced on this area, when it's actually here. So these limbs pushes wherever they are. If they're standing, they push onto the wall. If they're sitting, they push onto the plinth or the bed to maintain the center of gravity on this side. This is called as the pusher syndrome or the lateral pushing syndrome. And that actually occurs because of ventrolateral thalamus. I think I can actually check it afterwards. But it comes up as the lateral pushing syndrome or the pusher's syndrome because of unilateral neglect. That's it. Now, in this case, regarding the examination is covered. Other than that, flip a few pages because you don't have to cram or remember everything in this segment. You don't have to go through all this. Just remember this: the gated locomotion, in the stroke specific instruments. These are the ones for postgrad students or the ones that are doing masters or specialization in neurophysiotherapy. Now you need to jump onto the physiotherapy interventions, because in framework there's a topic also called as the framework of the stroke management. It's the same as the physical therapy interventions, and we can cover up the physical therapy interventions in detail after this part.